infancy is a little bit of a vague definition. We generally take infancy as 12 months, but for the purpose of definition of infancy period, we do go up to 2 years, right? So if the damage happens after 2 years, we don't call it cerebral palsy, because now people have found out that the brain grows in a different way up to 2 years. And there's a question. Oh, what? Chat one. Yeah. Sorry, I'm so sorry. I will record it. Yeah. How did I forget to record? Okay, recording, right? So, so cerebral palsy is a permanent disorder. It is not an ongoing disorder, and it affects the development of movement and posture, resulting in activity limitation. Now, when we are going throughout, I'm going to talk to you what is activity limitation. And it is caused by, or it is attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. The motor disorders of cerebral palsy are often accompanied by a group of other disorders. So it could be something to do with communication, sensation, perception, cognition, epilepsy, or behavior or musculoskeletal disorders. So what is sensation? Sensation means hearing and vision, right? So these children may have hearing and vision problems. Then um, what is perception? Perception means the way you see the world is different to the way that other people see the world. That may be because of your sensory problem, or maybe because of your understanding problem, but you won't perceive the things the same way as I do. So it may be because you don't feel well, or maybe because you can't hold something well. So because of your sensory problems, the way that you uh, perceive the world, or way that you capture the world is different. Okay, so for example, I'm going to show you my phone, right? So I'm saying this is my phone, right? So I'm going to ask from you, what is this? So majority of you will tell this is a phone, right? You may say that. But at the same time, if I show this to you, some of you might even say this is a phone. But actually this is not a phone. This is my hard disk, right? So they look very similar. So this also, now if I show this side without this part, this, you might think this is the camera, right? We don't know. So if somebody has not seen it, so it's somebody from Anuradhapura, from a very remote area, who is a farmer, somebody, he might think that my remote is a phone, right? So I also have sometimes thought, oh my goodness, I can't believe it. Is that so? We say that, right? So that is how we perceive it, right? So therefore, perception is the way you perceive things, but you can have sensory disturbances, right? And then your cognition may get affected. These children may have cognitive difficulties, they may have difficulties in communicating, behavior, epilepsy, seizures, or secondary musculoskeletal disorders. We'll discuss how they get musculoskeletal disorders as we go by. Okay, please excuse me for 1 second. Today I was in Colombo because I had some other exam work. So therefore I'm not at Ragalam, but generally I'm always at Ragalam. Gross motor function is the main area that is affected in children with cerebral palsy. You may see that in here. Sorry. Okay, sorry. Here we say that it's a disorder of the development of movement and posture, right? So that means the gross motor is most affected, right? So muscle tone, power, balance and coordination, reflexes. So can you all remember how to do a neuromuscular examination of the upper limbs? What do we do? First we observe, right? Then we palpate, right? Then we auscultate. That is the general way that we go in our system examination. So we do not auscultate in uh, muscles and bones, but what we do is we observe, we look for muscle wasting, or we look at the posture or whatever. Then we feel for the tone, then we look for the power, then the balance and the coordination, and then we do the reflexes last, right? So that is the same order that we are going to look at the gross motor function of these children. At the same time, all these can be affected in children with cerebral palsy. Right? So this is a woman who is balancing herself. Now, this is all because of tone, power, balance, coordination, and good reflexes in place. But this cannot be done if you have cerebral palsy. You will have to get some more supports in place to do this, right? So if you look at children with cerebral palsy, it is supposed to be, sorry, I haven't given the figure, no? It's about 2.5 to 5 per thousand live births, 2.5 to 5 per thousand live births. And if you look at the number of children with difficulties, the majority of children will have either hemiplegic cerebral palsy or diplegic cerebral palsy. Only 1/4 of the children will have all four limbs involved. But this is, remember, not from Sri Lanka. These are figures from very developed countries, right? Even if you look at how many can walk, you will see that 99 to 98% of children with hemiplegia and diplegia can walk. And also you can see, even if you take children with all four limbs involved, there is about 23% of children in each, 23 to 25% of children who can actually walk even in that category, right? This is quite scary because we don't have like that. Our children are about this much cannot walk. About half of our Sri Lankan children cannot walk. So what are the causes of CP, right? So primary inflammatory changes are resulting due to hypoxia and ischemia. You all have to excuse me for 1 second. I am getting a very important call, okay? Just excuse me for 1 second. I'm going to pause the recording. Hello, Dilip. Hello. Yeah, hi. I am at a lecture. I'm doing a Zoom lecture. Can I call you after this lecture? Is that okay? Okay, thank you. Thank you so much. Sorry. Uh, primarily, conditions, two factors contribute towards this condition, which happens in the brain. Okay, remember this is all to do with the brain, right? Either it could be hypoxic injury or it could be ischemic injury, right? And the maturity of the severity depends on the severity of the condition depends on the maturity of the brain. And therefore, they say to prevent inflammatory changes, we have to do cooling of the brain, right? So you put an ice cap to a baby who has hypoxic ischemic encephalopathy, they have better outcomes. Okay, remember this. That's a good MCQ point. Okay. Also, this is what happens. I told you all that children with prematurity are more likely to get damaged, right? So if you look at this, if you look at the survivors of cerebral palsy, the majority of children who have survived have survived the prematurity will have CP. But if you look at the total number of with cerebral palsy, you will see that even um, more than 37 weekers, there is a large number of children with CP. That is because if you look at a total population of a birth cohort, the majority are not preterm. Therefore, the majority will be more than 37 weeks. It's similar to the concept of women who have children with Down syndrome. It's true that if you are more than 35, you will have a possibility of having a kid with Down syndrome high. But if you look at the total population of women in the world, the majority of women who have children with Down syndrome are less than 35, because less than 35 is the general reproductive age group. I hope you do understand that. And this is called the paradox effect, right? So the paradox is very strong relationship between prematurity and risk of cerebral palsy versus the fact that most patients with cerebral palsy are born at term, right? So if you look at all children with cerebral palsy, the majority are born at term or less, right? But if you are a preterm, there's a higher risk for you to get CP. That is the fact here. Is that clear? Did you understand all that I have talked till now? If you all don't understand, please tell me. Is that clear, the paradox effect? I might ask from you at the exam. If you don't understand, you'll have to tell now.
Excuse me, madam.
Yes, tell me.
Can you explain that again?
Okay, sure. The fact is, if you look at this graph, you can see this is the gestational age in the x-axis, right? So if you look at the number of children who are born less than 27 weeks, you can see that there is a large number of children who are born less than 27 weeks having cerebral palsy. But if you look at, let's say there are 100 children with cerebral palsy, and if you look at their percentages, this percentage wise, this is a small factor. But percentage wise, look at the key percentage of all cerebral palsy. This large number actually represents a small percentage. So if you take 85 cases, right? If you take 85 out of, that is like, actually this is not cases, this is percentage wise cases. So out of 100 kids who are born, 85 will get cerebral palsy if you are preterm. But if you look at the total percentage of children, this represents only a small number. And you can see the number of children who will have cerebral palsy also increases with the prematurity. More you are premature, more you have a chance of getting CP. But if you look at the total number of children having CP, the majority of children with CP are term or more. That is actually because there are a lot of other causes contributing towards cerebral palsy during term perinatal period. Is that clear?
Yes, madam. Thank you.
If you look at this graph very carefully, you can understand. Now, if you look at cerebral palsy, it is primarily due to damage to three main areas in the brain. One is the cerebral cortex, the other one is the basal ganglia, and the third one is the cerebellum. Remember, they are all to do with motor, but if you remember your anatomy very carefully, all the cross sections that you have studied, you will understand these. It's true that they are motor, but the motor action of these areas are slightly different from each other. So the origination of movement is from the cerebral cortex. You know, there is a motor cortex that is responsible for movement of limbs and also even talking. I need some water. Right? Then if you look at the basal ganglia, now I'm moving my hand. I'm moving my hand. When I want to move my hand, it's the motor cortex that told me that I need to move my hand, right? But when I'm moving it, opening it slowly and closing it, opening it slowly and closing it. That is regulated by my basal ganglia. Okay, that's regulated by my basal ganglia. Then what does the cerebellum do? It does the coordination. So I'm opening, that is done by the basal ganglia, and then I want to touch my spectacles. So I take my hand here. That coordination from the place where my hand was to my spectacles is done by. Did I not put? What is the problem? There. Okay. Right. So when I take my hand to the eye, the spectacles, that is coordination. That is called coordination. Okay. So there is movement origination, movement regulation, movement coordination. Right. Three main components are there in the movement. That is what is actually helping us to maintain posture and move, right? So if I want to if my regulation of movement is not there, when I want to open my hand, some fingers will not open because they are not regulated, right? And then if I want to touch my eyes spectacles, it might go and touch something else, my hair, right? So the coordination doesn't take place. Excuse me. Hello, I'm at a lecture. Please call me after 5 o'clock, okay? Right? Okay. So, I hope you understand. So, cerebral palsy can take place due to damage to any of these three areas or a mixture, right? So, therefore, the clinical features are all to do with all these brain areas. Right? So you can see MRI changes in these areas which are relevant to the motor area, the basal ganglia, right? So these are the changes you will see in cerebral palsy, just to make it interesting, right? And how does the mechanism of injury and pathology take place? There is a primary and a secondary injury. Let's look at it. Primarily, there's an upper motor neuron lesion because it happens in the cerebrum, the basal ganglia at the nuclear level, right? Then, because of the upper motor neuron lesion is there, upper motor neurons are not working and controlling the lower motor system. Then what happens is there will be a lower motor neuron hyperactivity, right? So this is a very important picture for you to understand the pathology of cerebral palsy. So firstly, this is what happens. Loss of connections to lower motor neurons because that is the primary way that the upper motor neurons work, right? So then when the upper motor system is broken down, there's a negative impact. So there will be weakness, there will be impaired selective control, motor control, as I showed you, poor coordination, and also there may be sensory deficits, right? That is not due to motor, that is due to sensory, upper motor sensory problems. Similarly, there will be loss of inhibition of the lower motor neuron lesions that will have a positive effect of upper motor neuron syndrome, which means actually hyperactivity of the lower motor system, right? That will lead to spasticity, hyperreflexia, clonus, co-contractions, etc. Right? So that means there is now, if I'm walking, there is a mechanism that tells me put your right hand first, left hand back, right hand first, left hand back. But if that control is not there, there will be co-contractions, right? When my one hand is moving, the other hand will also move. So that will result in abnormal movement and posture, right? So the hyperactivity is actually due to neural loss is due to mainly non-neural like activities of the muscles that are mainly affected, right? So that will give rise to a lot of skeletal abnormalities throughout the body, including postures, contractures, scoliosis, hip displacement, bony torsions, right? So a lot of things can take place, right? So we need to know this is the pathology of cerebral palsy. Now you are maybe thinking, so it's such a depressing condition, this cerebral palsy. Why is this madam trying to teach us so much about it? If I tell you that we can prevent all these things and these children can have a beautiful life, I hope you will understand my passion in teaching all this subject. Okay, we can make a huge difference. Can we stop children getting hypoxia? Not always, right? Of course, very good obstetric care, very good perinatal care can minimize, but we can never stop getting hypoxia. Can we stop a preterm birth? Not always, right? So those things will happen, but we have a responsibility to make our children very functional. Okay, so that's a different story that we are talking about. So mechanisms of injury. This is so these are the possible pathways that can get affected. So all these your favorite pathways when you were doing anatomy: corticostriatal, thalamic, cortical, and corticocerebellar cortical networks, right? That will impair all these things. Basically, regulation, planning, coordination, learning, and fine motor skills, right? Then there will be also descending pathways that project to the brainstem and spinal relays and retention of circuits that normally disappear with maturation. What happens is in a baby when the main motor pathways are damaged, when the main motor pathways are maturing, there are ways that the main motor pathways go and inhibit some of the unwanted motor pathways that are there in the body, right? For the primitive survival of babies, you need certain pathways in the body. For example, there's something called the sucking reflex, right? So the moment you put something in the baby's mouth, they keep a sucking. If you touch the corner of the mouth, there's something called the rooting reflex. So the moment I touch, they will turn their mouth to that side, right? So these are reflexes that are important for the survival of the primitive baby. But when the baby understands when there's milk, I have to turn my head. That is a coordinated movement that happens through the upper motor neuron pathways. So when there's damage to the developing brain, while these reflexes are in place, while these primitive reflexes are in place, uh, the the inhibitory pathways will not work out because there's a damage to the upper motor neuron lesion. So those unwanted primitive reflexes will stay. So even a 5-year-old child with cerebral palsy, if you don't do proper intervention, if you touch their mouth, they will turn to the side, right? So that is not a learned pathway, it is a primitive pathway, right? So that is the meaning of the sentence: retention of circuits that normally disappear with maturation, right? So persistent or poorly inhibited primitive reflexes, abnormal organization of movement and posture, hyperreflective reflexes, and abnormal muscle tone including spasticity. So I will show you all the most interesting motor reflex, which is called the asymmetric tonic neck reflex. So that is called fencing. So when you are jumping over a fence, you lift your hand and you turn the other side, right? So and you put your other hand straight, and then you flex and flex your lower limb at the knee joint and at the hip joint, so that you will also be lifting your leg to jump over the fence. That kind of movement is called asymmetric tonic neck reflex, and a baby is in that position. I will show you other pictures. That baby can never turn to one side because ATNR or asymmetric tonic neck reflex will prevent you from turning, right? So we'll see some pictures as we go by and videos. So contributions to motor impairment, activity limitation in the critical periods of the child's development, restricted learning exposure, right? Because you have to see to touch to learn, that is limited. And you don't, the same kind of thing, the visual impairment and also the touch and all those, they will all come together and contribute towards motor impairment. But we can act on all these things and improve the child's activity, right? So if you look at cerebral palsy, there are different types of cerebral palsy. Children, I beg you that you should not be looking at old lecture notes. Excuse me, I'm getting a call from the faculty. මම lecture එකේ ඉන්නේ. ඇයි මේ හදිස්සිය අද disturb කරන්න මේ වෙලාවේ? මම දැන් මේ lecture එක 3ට ඉවර වෙනවා. මම 3ට තව එකක් පටන් ගන්නවා. ඊට ඉස්සෙල්ලා ඒ දෙක අතරදී මම ඔයගලන්ට call කරන්නම්. හරි? So I beg you children, please don't use old lecture notes because old lecture notes are not always correct, and we should move with the present day and the present teaching. So please learn new things and practice new things and become doctors of tomorrow, not doctors of yesteryear, right? So there are different ways that we classify the cerebral palsy. It may be according to the tone or it may be according to the gross motor abilities, right? So if you look at tone, there's spastic, there's dyskinetic, there's ataxic, and there's mixed, okay? And also there is a very small percentage of children who may be hypotonic, low tone, right? So spasticity is something, dyskinesia is another thing, ataxia is another thing, mixed is could be any of these together, and hypotonia is low tone. Okay, so you has spasticity. This child has dyskinesia. This child has ataxia. It's not easy, but you should be able to do that, right? Spastic is the ones that we divide as hemi, di, quadri, tetra, and triplegic. Dyskinesia, there are two types. The dyskinetic ones who have abnormal movements, especially the choreotytoid movements, or the dystonic ones. The tone is increased, right? Or ataxia means their balance and coordination is affected. So you may see that spasticity comes from the cerebral cortex, dyskinesia comes from the basal ganglia, ataxia comes from the cerebellum. Yes, Daddy Gamo, you can tell me what is your question. Hello. Who is Daddy Gamo? You all have a question? Anybody has a question? I can't hear you. You raised your hand, but I can't hear you. Hypotonic CP is most of the time the dyskinetics and the ataxic may hypotonic to start off with. Okay, but later on they might have some movements and some balance and coordination problems. So what is hypotonia? Hypotonia is abnormally increased resistance to passive stretch, and spasticity is resistance to externally imposed movement increases with increasing speed of stretch or speed of angle. So they are very similar, but please listen to me again. Hypertonia is increased resistance to passive stretch, right? So now I'm going to show you what that is. So now if I take my hand and if I stretch it, right, when I'm stretching it, if I feel there's a tightness, that is hypertonia, right? So generally in cerebral palsy, now when you go to the wards and when you look for tone, you generally roll, right? Roll the limbs over the beds. But in cerebral palsy, we generally stretch and see. You stretch and see whether there's an increased tone. You stretch against the joint, stretch a limb against a joint. So this is the shoulder joint, this is the elbow joint, this is the wrist joint, right? So you can just passively stretch and see. And if there's an increased tone, if you feel the tone is high, that could be hypertonia. Spasticity is resistance to externally imposed movement. So this, when we are doing this externally imposed passive movement, if you do it with an increase in speed and then you feel a resistance, that is called spasticity, right? I'm going to show you a video in a moment. So right, so topography is how it is distributed, the distribution area in the body, right? So there's unilateral CP or bilateral CP. So these are the possible ways that they could be affected. I'm going to share the slides and you will understand. So this person has quadriplegia, which means all four limbs are equally affected. This person has all four limbs affected, but at different degrees. Lower limbs are more affected, and then you call it diplegia, right? Then it could be monoplegia or hemiplegia. Right, so these are the possible percentages and the areas of brain damage, right? So this is the hypertonic kids, could be any of these, right? So I showed it to you a little while ago, same definition. So again, if you look at them, the regional, the unilateral ones, monopoly of them spastic. Right? Tonic ones are the global ones or the more generalized ones, and there are also extrapyramidal reasons for CP. Right? So these are the areas. The pink areas are the ones that get affected. This picture is very helpful. Okay. So when you are seeing a kid, I want you to describe the kids in all these possible ways, right? So it's the same thing. These videos never work. I show you the videos from the hard disk, right? Okay. Before we go to the functional classification, uh, let me show you the videos. One second for the hard disk, because I took the hard disk up and put it somewhere else. Yeah, I'm going to show you the video. Yeah, let's see. I'll show it again. Okay. So did you all see that? So the first attempt was slow phase. Okay. So the first attempt was slow phase. Okay. Then what did I do? Then I did the same flexion and I extended it fast. And then I felt a catch. So this is examination for spasticity. Look at it again, right? In the slow phase, I can do the full range of movement without any difficulty. Also, now look at the next one. In the fast phase, what happens? In the fast phase, there's a catch, right? There was a catch, so it was only able to do to a certain extent fast. The rest of it I have to do. So when it stops at that place, when it goes and stops at that place, that is called, from there beyond is the dynamic contraction. So look at it again. You can see from the very place where it stops. Now the fast phase you can do the whole range of movement. In the slow phase, that's the stop. So at that point, till the full range, that is the angle of the dynamic contraction, right? So the first one is called R2. This angle is called 1. So R2 minus R1 is the dynamic contraction, right? This bit is the dynamic contraction. Is that clear? Is that clear or not? තේරුණාද ළමයි? නැත්තම් කියන්න please. ළමයි, please don't behave as if you are okay. Right. ඔය දැන් කිව්වද ෆයිනල් එකකට ඇවිල්ලා මෙලව හසරක් දාන්න විභාගෙට ගිහලා පිස්සු කරනවා ලැජ්ජාවේ බෑ මටත් එක්ක. Okay. Now if you look at this child, it's a picture. Okay, is it? So madam is the first stage hyperkinetic. Okay, so all types of children with spasticity, there is nothing called hyperkinetic. There's something called hypertonia. Majority of cerebral palsy, you all know this. If you have an upper motor neuron lesion, that is hypertonia, right? Almost all types of children will have increased tone. Now if you look at this child, you can see this, sorry, let me say whether I'm sharing this screen. No, I'm not. Okay, okay, share. Now look at this kid. Look at the limbs, the way they are kept. Can you see the upper limbs? Can you see that upper limbs are kept in a flexed position and lower limbs are hyperextended? So this child has increased tone in the body, right? From a distance you can see. When you see increased tone in the body, this is a child with hypertonia. But you can't without touching and checking for that thing called, which is the catch. So when I'm doing the examination, I can feel a catch. That is where I stop saying there's a dynamic contracture, right? So unless for spasticity, you have to do that examination around the joint to look at the range of movement in the slow phase of passive stretch and in the fast phase of passive stretch. So slow phase I do, fast phase I do. I feel a catch. So that is spasticity. But if I'm keeping my hand like this, you can look at me at a distance and say that person has hypertonia because I'm keeping my hand in a hyper extended position, same as this child, okay, in this picture. So this child is having hypertonia of limbs. But if I want to see whether it is spasticity, I have to do the passive stretch with an increasing speed, right? So speed dependent passive stretch, when you do that, if there is a catch, there's spasticity. But if you see a child keeping a limb like this, and you can see from far that this child has increased tone, that is most probably due to the condition called dystonia. The tone is so abnormal that you can even view it from a distance, right? So these are the types of increased tone that you will see in cerebral palsy. There are two types of increased tone that you will commonly see. One is dystonia, the other one is spasticity. Both these are called hypertonia. Is that clear? You can get a mixture. So just because you can see here from far away, this child has increased tone, which is hypertonia, and when you can see with your eyes, that is called dystonia. And when you still, if you see with your eyes, you need to go and touch and examine for spasticity and see whether there is spasticity or not. This is a tough lecture for me to do by Zoom, but if you can understand, there are several types of hypertonia. The commonest ones are spasticity and dystonia. For spasticity, you have to do the passive stretch against resistance. With increased resistance, increased speed, the resistance is more. Dystonia is what you see. If you understand that bit, I'm happy. Do you understand it or no?
Yes, madam.
බලමු මොකක්ද
I understand.
දැන් තේරෙන්නේ නැහැ කියලා වගේ එකක් ඇවිල්ලා තියෙනවා chat එකේ. නෑ. අලුත් එකක් නෙමෙයි. කො අලුත් එකක්. Okay. Right. So I hope you understand that. That is the maximum I can teach you in a Zoom lecture. If you were with me, I would have done it and shown it to you, but hopefully someday we'll meet in person for me to teach you, right? So I will also share an article about hypertonia. Then maybe you will understand what I am saying, right? Okay, I don't want to further confuse you all with a lot of videos. I will move on to the lecture and we'll see some more videos as we go by. So also now you understood how difficult it was for me to explain to you this spasticity, dystonia, to hypertonia, all this nonsense, right? So therefore, this is not you and me only. This is universal problem. Everybody is having this problem. So therefore, they have brought in a new classification called classification based on the functional level of children with cerebral palsy. This is what we commonly use, right? And that is called gross motor function classification system, and it's very easy. It's called the GMFCS. GMFCS, and it is from level 1 to level 5. So it is a common language, and it's based on the ability of the children. How the child can mobilize. The child can mobilize indoors and outdoors, climb up and down the stairs without any support, and does not need any support, and there's no limitation. They will do everything, but if you look at them in running, jumping, speed, balance, and coordination, there may be minimal impairments, right? Then, if you look at GMFCS level 2, they might need a little bit of help to move around, especially when they're climbing stairs or uneven spaces. 3 kids can mobilize around even by walking with assistive devices or for a short distance. By the long distance, they will go by the wheelchair. GMF says level 5, 4, they will majority of the time they will be on the wheelchair, but tiny distances like going to the toilet or something like that, they might do with a device, right? Level 5 is always in the wheelchair. They need the wheelchair to go everywhere, and they will even not have head control, right? So it's very easy for you to remember this. Remember, level 1 is the best, level 5 is the bad, worse. If I get you for the exam and if you get CP, I will definitely ask what is the level of GMFCS, okay? And the good news about GMFCS is, if you look at this, you will see all children less than 2 years are not well defined into the GMFCS level. So again, this is where we have to say, we have to pick up these kids well before they are 6 months and then do interventions so that we can change their pathway, right? So if they are supposed to go to level 4 at this point, if you push them and if they work, they might go to level 3 or even to level 2. You can see that they are very close to begin with. So depending on early intervention, we can decide where actually they are going, right? So we can diagnose them through examining them routinely, that is called screening, or maybe looking at secondary complications, right? Then we will also need some investigations like the MRI, etc. And this is like the CP guidelines. I'm not going to go through this. These are the international CP guidelines. When you don't know the diagnosis of CP, there's a child who is at high risk for CP, just start initial interventions, right? Don't wait. That is the first guideline, right? Urgently start the interventions, right? So they say there are things like, if you do the MRI, and there's an assessment called general movements, which you will learn when you're doing clinicals. If you do that, you can have a 98% predictive value for cerebral palsy, right? If you so I think that video is working either. So that is how we put a baby and do the general movement assessments. Then if early detection is not possible, at 9 months, if they can't sit independently, if they can't take weight through feet, or they have hand asymmetry, then that is also highly suggestive of CP. So by 9 months, all children with CP should be identified. That is the basic message in international guidelines and referred for specific interventions. Okay, I'm not going to go through all, but I'll share the tiptoe walking, abnormal movements, or in the history, they will have these possible risk factors, right? Okay. So we also have the child health development record, which might be helpful. And also we can look at the head circumference, because some of them can have microcephaly, right? So remember, when you are doing an examination, we have to do the head circumference, we have to do the neurological examination, some areas of development, and then the GMFM is not for you all. That is another assessment. So you can get microcephaly, low tone, high tone, uh, persistent asymmetric tonic neck reflex, and exaggerated tendon reflexes, and upgoing plant and clonus. I'll show you the pictures, right? Just to tell you what is a dynamic contracture and a static contracture. So usually you keep your joint in a flexed position and you open it. That is the slow phase. You have a R2, right? Then you do a fast phase, and when you do the fast phase, that is the point of catch, and that is the R1, right? So R2 minus R1 is the dynamic contraction. But if you, when you are doing the slow phase, and in the slow phase, if it is not moving, that is the static contracture. Please remember that, right? Okay, so the child, if you are doing the slow phase, if it stops at this, that means beyond that it's not going. That means there is a contracture in this full range of movement. So this bit is a, if even in the slow phase, if there is no movement, that means it is a fixed joint, right? So you need to know what is a static contraction and a dynamic contraction, right? I'm not going to discuss this. This is a bit complicated, but so basically in the same child there can be a static contraction and a dynamic contraction. That is what is shown in this, right? So this is what happens. This child will have a, this red one is, this is the, this is the static contraction and this is the dynamic contraction. Okay. So you should be able to carry out a simple developmental screening. I will teach you all about developmental assessments later. And then I'll show you the other video. So these are the investigations we are routinely doing for all children with cerebral palsy. And remember, there may be other conditions there with children with low tone. The lecture is very, sounds easy, but actual sense CP is not that easy, right? Then there may be other very serious conditions which can give rise to abnormal movements, dystonia, developmental regression, and toe walking in autism, right? Also, after that, after doing the basic medical assessments, we can ask our physiotherapist to do a gross motor function assessment. That is about all the abilities of these children to achieve little skills like turning, sitting, reaching for a toy, things like that, right? Then you can ask the occupational therapist to do a upper limb functionality assessment, right? This is all to do with the upper limb functionality, right? This is all about that. I'm just sharing the slides, but you don't need to know about the ability to tie a lace, about the ability to drink with a cup, write letters, etc. So that is the occupational therapy. That is the hand function assessment. Yeah, all these are hand function assessments. Then we can get the language assessment and the feeding assessment, right? Then we can also look at how the mind is working, the cognitive assessment, the memory, taking decisions, learning, etc. Then the visual assessment. About cortical visual impairment, I will teach you when you come to the final year. I'm teaching the SHS students today, but this is a bit too much for you all at this moment. But SHS students need that because that is to do with the work that they are doing, because they do interventions from very young ages, right? Then how they walk, how does the child walk, that is gait analysis. And also these are called ankle foot orthosis, where you put these kind of braces to the legs to improve the alignment, how they stand and how they bear weight, so that child won't develop foot deformities, right? This is not to support, this is to improve the way that you align your body. When you fix these things, they can keep your body straight, so that it helps you to put yourself into proper center of gravity, Gurutva Kendra, right? To put your body into proper center of gravity, so that the weight doesn't go in this axis, but the weight will go in the proper axis, right? Okay. So we have to assess children and offer interventions at the earliest possible time, and it's all about the brain. So this is the neural plasticity theory, where the brain has a critical window to develop best, right? So if you look at the brain development, everything is done and over by the age of 12 months, right? So during this period, you have to give the best exposure to the children, right? So that children will learn to see, to hear, to talk, and also to think. And also, I showed you the previous one how the motor learning takes place, right? So, to make the child more functional, that is our main aim, and address the needs of the child and the family. There will be a multidisciplinary team looking at these children and supporting. And we have to see, this is the ICF. I have taught you the ICF. According to ICF, we have to see how we can change each component, the body structure and function, environment, how to build up the personality to improve the activity and participation of these children, right? Remember this. So intervention plan should have goals that are based on the family's needs. So family says, I want my child to walk at 2 years. You have to work towards that. If you can't make the child work at 2 years, you have to tell them, I'm sorry, I won't be able to do it at 2 years, but let's see, let's try to get the child first to sit down by 2 years. So we can manipulate the goals the way we want. So you need to know the child development sequence and also to see how you can teach the parents to play, how to make interventions regular, consistent, and how to use home-based stimulation, right? Okay, there are a lot of strategies. There are uh, things like medications that we can use. So these are some of the drugs that we use. We are giving botulinum toxin to some of these children, very selected kids, but we often treat them with benzexol and levodopa, right? Long-term musculoskeletal problems, I showed you what they can get. Good. Go through this. And also there could be surgery required for some of the kids with lot of bony torsions, etc. Right? Um, this is about the AFO, so you can read about it. That tells everything. Remember, these children also can have epilepsy, visual impairment, hearing impairment, drooling, gastroesophageal reflux disease, constipation, behavior problems, and also a lot of other complications like recurrent chest infections, urine tract infections, risk of abuse, right? Remember, risk of abuse, right? And you have to look after all the other needs of these children, including nutrition and immunization. Okay, so we have to do these things, and also there's a very important thing. Please remember, they all need hip x-rays to make sure, because they are abnormal in their posture. There is no selective upper motor neuron control. Their muscles and bones are not properly coordinated, so they can get hip dislocation. So we have to do regular hip examination and advise them on certain types of activities to prevent hip dislocation, right? So these are some of the medications we can use, and in the long term, remember, they need to go to school, they need to do a job, they need to have families. So we need to advise them about these things, right? Quickly to show you all a few videos. We have about half hour. Um, Let me show you all some videos and let's discuss about the types of gaits, etc. Okay, look at this guy walking and tell me what his gait is like. Look at this guy. Okay, somebody tell me what is the way he's walking. I don't know how to play it slow motion. Is there something wrong? My keyboard minus button. While it is playing, that is actually what we are doing is called gait analysis. So yeah, tell me what did you see? What did you all see? Can I show you another video of him? A different angle? Um, so I showed you two different ways. There's another video. Okay, right. Any ideas? What do you think that? Okay, good. Okay, so there's tiptoeing. It's not a monoplegia, it's actually a diplegia. Both legs are having problems. Monoplegic kids will walk more steadily. This one is having more tiptoeing on the right side. I agree, the right side is more affected. So this is the issue, right? So the right side is more affected, but both lower limbs are affected. If you look at the video, you can see that the child is having inversion of both feet, and he's going slow. He's going very fast to prevent him falling. So the same boy, I'll show you all again. I hope it's working. Some of these videos are not working and it's a bit scary because all these are images. Let me see. Okay, it's working. Let me show you. Yeah. So his right side is more affected. His left side is also affected. You can see he's wearing braces. These are not the best braces that we talk about, but he's wearing braces. So yeah. So he's he's uh, having it's a diplegia. Actually, if you have to see when it's diplegia, you have to get him to sit down and work, and then you will see him working with his hands. He's a boy who's going to school and doing really well at school, but he has some walking difficulties, right? So I'll show you this girl because I wanted to show you different types of CP. So this child, if you look at this child who is sleeping, the child is not turning, right? This is a 2-year-old child. So you can also see that the child has abnormal movement of her limbs. Now these are dystonic movements, right? If you look at them, they are not. She's just tightening the lower limbs, but actually there is no purpose. So she can't move, right? She also has a visual problem. She can't fix. So she has very little ability to do things. You can also see the right upper limb is fisted. So this fisting is because of the increased tone, hypertonia and dystonia, because you can see the increased tone from a distance. Spasticity is something that you can't see from a distance, right? So that's another one. Um, okay, I'm going to show you a hypotonia one also. Mm, sorry. Okay, look at this. Can you see how low her tone is? So she's DMF says 5, right? She's DMF says 5, and she has very low tone. She has no head control. Now see, when I'm giving her the bell, she wants to. So she has motor initiation. So possibly her cerebellum is fine, cerebrum is fine, motor cortex is fine. So she initiates. But if you look at the way that she is, look at her motor coordination. See the way that her movement is coordinated in a very um, abnormal way, right? So possibly this is a child with basal ganglia damage, and these are abnormal movements which are called dystonic movements. You can see even this hand has gone into fisting. Sorry. So this is a hypertonic kid. Let me show more videos to you all. Okay, this is a severe dyskinesia. Can you see what happens to her hands and legs? So this is Dinebi. Dinebi is a very bright kid, but she can't talk. Can you see what happens to her legs and her hands? All are going into abnormal tone, right? So this is called dystonic cerebral palsy because this is not spasticity that you see. What you see from distance is dystonia, right? Can you see how her hands and legs are going into abnormal position, right? So glasses show you a very severe dystonia, worse than even this. Uh, Usually, we don't see that amount of severe dystonia now. Even many of the consultants would look at this child and say, severe spastic quadriplegic CP, that is wrong. If somebody calls this child severe spastic quadriplegic, that is wrong. This is not spasticity. This is severe dystonia. Severe dystonia is what will put you in that opistotonic position, right? So this is not damage to the cerebrum, the motor cortex. This is damage to the basal ganglia. When there's damage to the basal ganglia, children go into severe postures, abnormal postures, right? Because of their lack of muscle movement coordination, right? Movement coordination is because of those spinothalamic, those tracts getting affected, right? Can you see? So this is severe dyskinetic cerebral palsy, which is quadriplegia and also GMFCS level 5. Okay, clear? Is that classification clear to everybody?
Yeah.
Yeah, spastic, you can't actually see. If I want to see whether this child has spasticity, I need to do that examination technique which I showed you all. You have to do the passive stretch with increasing velocity to see whether there is a catch. Now this child, you can't do that because this child already has a very high tone. So when there is a dyskinetic cerebral palsy, it's very difficult to assess for spasticity because dyskinesia overtakes spasticity. Clear? Because when there is increased tone in the body, when you are examining throughout, and you can't actually look for spasticity because you can't do the slow phase and the fast phase. So what you see is generally dyskinetic. So this is severe dystonic cerebral palsy. That has to be the diagnosis. You can't comment about spasticity in a child like this. Clear? Spastic children are not like this. Spastic children, now that boy who was walking, that is a kid with spasticity. Because when you do the assessment, you will see that there's a cat. Yeah, but otherwise, he most of the spastic kids can mobilize their limbs. को प्राश्य यहाँ बुलाया. Is that clear? So with this degree of dystonia, you can't assess for spasticity. There are kids that we can assess for spasticity with dystonia. Yeah, wait. Hmm. Okay, now this one. Look at this one. Wait, I'll share it. Yeah. So this one might be spastic. We'll have to examine and see, right? But now this one also again lower limbs only. But of course, if you look at the lower limbs, you will be able to feel the spasticity, right? So this is possibly a spasticity. Now, the same child, I'm going to show you all as a baby. This is one of the kids who had wonderful results. It doesn't even count. Yeah. Now, this is the same child. You can see that she can't even, she's not even turning at 7 months. She's just staying like a rock, just like the previous child we saw, right? So, this is the same child who improved to walk. Let me show you something else. Okay, yeah, the same one I'll show you. Yeah, I'll show you this. Now see, it's a baby, right? This is 6 months. She's not turning. She's not turning. If you look at her hand, this is kept in a more kind of flexed position. So there may be a tiny bit of dystonia. So she's refusing to turn. We are trying to posture and movement problems shown very early. And where she finds it difficult to turn. Okay? Right, so posture and movement difficulty shown early in life. Uh, I'm going to show the same child to you all when she was bigger. I'll stop in a few minutes. It's on a different lecture, but I'll show it to you all, right? I hope you all can see. Okay. I don't know, it got disconnected and connected again. Just one last video to show cerebral palsy in a very early baby. Uh, this is cerebral palsy in a baby. You can see that he's not moving at all, right? Log. Very restricted movements, right? So we can diagnose cerebral palsy even less than 5 months. Can you hear me? Yeah. Yeah. So unstable internet connection, I don't believe it. Yeah. So just to let you all know, in a summary, cerebral palsy can be early diagnosed and intervened properly. They can become functional, but the definition is a non-progressive damage to the developing brain, right? And which will result in activity limitation, and there are these motor and posture things. In addition to that, you can have a whole array of difficulties in these children. But if we work as a team, we can improve them. From your point of view, you need to know that early intervention can make a difference. You need to know examination, spasticity, dystonia, dynamic contractures, static contractures, all the other complications these children can have, and what medical advice we can give, and how to work within a team. That's all you need to know. When we do clinicals, we'll learn more. I will try to write a little handbook for you all, how to examine a child with cerebral palsy, if I have time. Okay, thank you. Any other questions? You can email me. You have my email. I will try to upload this onto the Cal. I don't know whether I have access. I need to check that. I didn't have time to check it. Yeah? Any questions before we stop? Okay? Done? Thank you. I hope you'll have some knowledge of CP when you come. I will also send you two important articles, right? Two or three important articles. There's one which you can use as a textbook. There's one about hypertonia. There's one about cerebral palsy diagnosis guidelines. So I'll send everything to Asanka. Is that okay, Asanka? Or if I have access, I'll upload it onto the Cal. Right? Thank you. I have another lecture and I had to return two calls. Okay? Thank
Thank you, madam.
you.
Thank you, madam.